Hello, my name's Naomi Slater. I'm one of the spinal neurosurgeons at the Trust here, and I've been asked to give a bit of an introduction to spine, spinal injuries, and a bit about spinal cord injuries. So, welcome. So first, some of the aims that we are going to start with today. So we're going to go through some general anatomy, general terminology, a bit of understanding about the principles of disease and pathology, a bit on understanding the mechanisms of the injury, a bit about clinical assessment, management of spinal cord patients and spinal injury patients, which are two slightly separate things, and a bit on about collars and braces, some more practical aspects. So, firstly, to terminology, we just need to understand how we talk about the spine. So, some basics. This plane is the coronal plane. So, if you slice yourself down in half all the way down, this term is the sagittal plane. So, this is where if you slice it down in the middle, cut down through, and then we've got axial planes if you've been chopped through the middle. If you've got something just to the side, then that's the parasagittal, and I'll just go through some scans now to explain that. So this scan that we've got on the left-hand side of the screen here, this is what a coronal of a lumbar spine looked like. So this is if you've chopped down through this way, so you can see a front-on view of the spine. The sagittal plane is the side-on view, and this is probably one of the most useful ones that we use in spine. And then these final two pictures are axial views of what we see when we're doing imaging of the spine. So a bit more about terminology. So obviously you've got your right and your left, and actually if you're looking at imaging, then they're the opposite way around, remember. To the midline, which is medial, and to the outside, which is always coming lateral. Distal means down towards the feet, proximal means up towards the head. You've got anterior is ventral, and then you've got posterior is dorsal, and then superior and inferior. So just basic terminologies that we will use as we go through the talk today. So, functions of the spine. It's got three main functions. First one is protection. So this is protection of the spinal cord and the nerves, but also protection of all the organs around. So it's really important for some of the retroperitoneal organs, such as the pancreas, the stomach, and various other things. That protects those. Structure. Without the spine, we had nothing to hang our skin and our bones on. So it's really important for maintaining our own posture and in order to provide a framework for everything else to sit on. And mobility, so the spine is mobile in multiple flexible planes in order for us to move about as we like. So, avoiding the occiput and the top of the cervical spine, there's 6 planes of motion. So you've got flexion, extension. Most of this happens at the lumbar spine and cervical spine, very little within the thoracic spine. Lateral bending, this is more of the remit of the thoracic spine, and then left and right rotation, which happens again in the middle. Right, so our vertebrae, we've got 3 regions. We've got the cervical, the thoracic and lumbar, and then you've got the sacrum and the coccyx, which is one fused bone that comes down. Depending on the region of the vertebrae look quite different. So you can see the cervical vertebrae at the top, the body of the vertebra, which is the top bit, is quite small. This is because this isn't so much a weight-bearing vertebrae because it's at the top of the spine. As you come down, you can see the body of the vertebra gets bigger and bigger as you're taking more and more weight and load through the spine. So we've got 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and sacrum and the coccyx. There are sometimes some times where you can have different numbers of vertebrae when you've got congenital anomalies, but this is the standard that we all learn. When you've got 2 vertebrae, each area where you've got 2 vertebrae met together, that's called a functional segment. So between, say, vertebrae 6 and 7, that would be called a single functional segment. And this is where the nerve comes out and the spine comes down the middle. So, not just bones, but ligament and muscles are just as important in spinal integrity. So the spine is made up of the 3 things. You've got the bones themselves, the ligaments and the muscles, and those are what makes up spinal stability. And this is why it's so important sometimes when we're asking for MRIs. A CT scan is really good for looking at the bones, but the MRI actually looks at these ligaments and the muscles. And quite often you won't necessarily see a bony problem, but if the ligaments and the muscles are injured, then that's just as important as having a bony problem. So this is one level deeper. These are some pro-section pictures of what the brain and the actual spinal cord looks like. So you've got the brain up here, coming down to the brainstem and then spinal cord, and at each level you've got spinal nerve roots that have been cut. At the bottom you've got the cauda equina, which usually sits around L1 body, and then you've got the nerves of the lumbar spine coming out at that level. This is what sits within the bones. This is the spinal cord, and this is structure. It's contained within the meninges, so what we know is the dura. There's 3 layers of the dura which make up the meninges, and within that you've got the spinal cord. At each level of the spine you've got a nerve root that comes out that supplies a particular area of the body. So, a bit moving on to spinal pathologies. So, most of the spinal stuff that we're going to be talking about today will involve trauma. So, it's probably the most important in the ITU setting and the major trauma setting. However, in terms of the disease mix that we see, the vastly most common thing that we deal with is degenerative disease. There's also other important diseases that we will come across, such as infection, tumours, so this can be tumours that have been spread from somewhere else, or tumours that have grown from within the spine. Intrinsic problems, so you can have problems within nerves, and often these might be neurological conditions such as MS and motor neuron disease. You can have vascular problems, and you're going to have congenital problems. So, spinal injury. There's really 3 groups that we look at when we're describing spinal injury. We can either looking at a spinal column injury, so that's looking at the bones, ligaments and muscles. And we can describe that in different ways. Sometimes you might describe it in a location, so cervical thoracic. You can describe it such as structure, so is it a bony problem? Have they disrupted a disc problem or a ligament? Or severity, is it stable and unstable? And we'll go through each of these. Then we can look at spinal cord injury, so this is actually looking at the nervous tissue, and this can either be complete, so loss of everything, incomplete, or transient, they've recovered. Or you can have a combination of the 2. So, mechanism. How do these types of injuries occur? Well, any type of injury can occur in any way. The most important distinction is between the 2 is compression and distraction injuries. So compression, these ones at the bottom, distraction, the ones at the top. The reason being, if you have an injury where mechanism where something is pressing down, that tends to crush bones. So if you've got ligaments and muscles, those tend to have a less likelihood of being disturbed. If you have a distraction injury, if you're pulling things apart, not only do you disrupt the bones, but you're also tugging on the ligaments and the muscles, and that tends to have a much higher impact because you don't have those ligaments. If you've torn through the ligaments and muscles, you don't have any integrity of the spine. So we tend to see much more severe injuries when you've got something in distraction rather than with compression problems at the bottom. So, some examples of mechanisms. So probably the most common ones that we see are hyperflexion and hyperextension injuries. So hyperflexion injuries are when the neck is flexed forward and there's been a compressive force on the top of the head forcing the neck into flexion. So the typical one, this is described as diving injuries, people going to a swimming pool. However, probably the most common one that we would see here are with low impact falls, particularly into a wall, or in somebody's tripping forward and then goes into something and then they have an impact on the top of the head. That's by far the most common. You get this also with low speed RTCs, and typically, not the cervical spine but the lumbar spine, you can get these kind of flexion injuries with a seatbelt, typically the ones that would go across your lap, because when you're in an accident then the spine would bend forward at that level, so that gives you the kind of thoracolumbar flexion fractures. Hyperextension, so these can be low speed RTC'd and also falls where the person's fallen forward, landed, and that's forced their head up. So you might often see an injury to the forehead or a scab on the chin might be typical of somebody with a hyperflexion injury. You also get these with seizures where people have had a seizure and an uncontrolled fall and therefore forced into hyperflexion. Compression, so that will be a direct impact on the head, so this can be a fall from significant height or quite often blunt force trauma. So if somebody's hitting on the top of the head, that's going to cause compression injuries. Distraction injuries and dislocation injuries, as I said, they tend to be much more high severity injuries. It takes much more force to pull apart the spine and disrupt all those ligaments and muscles. So you tend to see these with very high speed injuries, falls from multiple stories, high level motorcyclists, or a high impact RTC. Also you see them in the military with blast injuries. And the last group is spinal cord injury without radiological abnormality, and this is quite common, particularly in the elderly population. The CT scan and x-rays may look totally normal, but they've got a spinal cord injury. Now this happens because usually at the force of an impact, the spine may have bent forward or bent back, but that's only happened for a transient, short amount of time, and then it's gone back into alignment. So you can't see any abnormality on the x-rays, but for a period of time they're either in hyperflexion or hyperextension, and that's caused them to have a cord injury, but there's nothing to see on the CTs. So this is just, you don't need to know all of this. This is just to give you an idea of the classifications of factors. There's loads of classifications of factors, but the O classification is by far the most common we use. And you can have these slides and you can have a look at these. But it's just a way that we put together different types of fractures, usually 1s to 3. So 1 is the most easy fractures and the least severe, and then A's to C's are more severe. So as you come across here, the severity of your fracture increases. So that's what we talk about at the neck. You've got the same system talking about lower down the neck. Essentially you say A's the least severe, going up to C's being more severe, and coming across the more severe the injury, and it's exactly the same for the thoracolumbar. By far you get worse injuries as you come across up to C's. Okay, so a bit about actual management. So hopefully if you're managing a patient in intensive care, they should have already had this gone through. But if you're in A&E, or if you're going to be doing some pre-hospital care, it's important to know when you should be immobilised in the cervical spine. So pretty much everywhere now is using the Canadian C-spine rules. So basically what this says is, do they have a mechanism that is likely to be causing a C-spine problem? And does this something need an X-ray? So you follow down the flow chart. So age, dangerous mechanism. If it's a low risk, then you can be reassured and go on to examine your patient. If they do not have a low risk factor, then you go on to immobilisation. I won't go through all of these, but most of these patients should have already been triaged by the time we're coming into hospital. It's really important as well that you acknowledge if the patient is a non-trauma case or if they've got a reduced conscious level, because you cannot assess the patient if they're intoxicated or they've got a head injury or they've got another reason why they can't be fully assessed. They also all need to be managed in the collar. This is our current guidelines in North Bristol Trust that we use in our A&E. So it's very similar to those Canadian C-spine rules that you go down the flow chart. If they meet any of the criteria, then you put them on full spinal precautions and then go ahead to imaging. So, how do we clear the C-spine? So the most important thing is they are awake, they're alert, they're orientated. They should have no other distracting injuries, or if they do have a distracting injury, that needs to be well managed and they need to be pain-free from that distracting injury. They need no drugs and alcohol on board. And they should have no pain on examination. So the first part of examination to clear the C-spine is to assess if they've got any midline tendons. So you feel from the top of the occiput, feel down with your fingers with them lying down, and if they have no pain on that, then you can sit your patient up. If when sitting patient up they continue to have no pain, then you can carry on to examine them. And what you want them to do is you ask the patient to actively rotate their head 45 degrees each way. It's important that they actively do it and that you don't move it for them. If they can do that pain-free, you can clinically clear the C-spine and they need no C-spine precautions. If you are in the pre-hospital field, it's important to know how to manually immobilise the C-spine. So this person's doing an excellent job. You hold it with the head in both hands, and it's really important that you don't cover the ears. That's probably one of the most common mistakes when immobilising manually the C-spine, is people cover the ears, and that makes your patient panic and more likely to move around. You cannot put a collar on with just one person. You need one person to hold the head and a second person that will come and put a collar on for you. These are the types of collars that you're likely to encounter. So in the pre-hospital setting, this is what you get given. So these are a very basic heart collar, and that they are sized to fit everyone. So you can move the size, and we'll go through that on the next slide of how we actually size a collar. In hospital, we usually use either one of these three collars. They all do exactly the same thing. It's usually just which ones are in stock. So here we use the Miami J, but other trusts might use the Aspen collar or the Philadelphia collar. They all do the same thing. So how to apply a collar? The most important thing is sizing it. So you use your hand as a size guide, and you have the patient in a neutral position looking straight ahead. Use your hand to size between the chin and the angle of the shoulder. So it would usually be about 4 or 5 fingers depending on your finger size. You can then use that on the sides of the collar. There's 2 lines on the collar that you put your hand across, and there's an adjustment on that will fit to the size of the chin, to the shoulder, and to the size of the collar. Before you put the collar on, you adjust it and lock it into position via this little blue knob and this little arrow. So this moves out, and then you can move the collar up and down. So you adjust the size before even going anywhere near the patient once you've measured the size. With someone else holding the neck, you slide the collar in behind, and then it should have one Velcro strap for a standard hard collar that will Velcro across onto this side here. This is what a well-fitting collar should look like. So the collar sits underneath the chin. Probably the most common mistakes with collars is their Velcro straps on either side aren't done up tight enough, so that the chin either slips within the collar or there's movement under the chin. That should fit really tightly right up against the angle where the chin comes down to the front of the throat, and so that the chin is nicely rested. They should have no movement within that, and they should also make sure that they've got nice padding along either side, because the second most problem is that you get rubbing of the collar, and that's what people find uncomfortable. So as long as those 2 areas are padded and the chin is sit nicely inside. If you're in the pre-hospital setting again, a collar on its own is never going to be enough. You always have to immobilise with a spinal board and spinal blocks until they can be cleared. So they should always, if they've got a collar on, they should always be in combination with a spinal board as well. You should never have one without the other until they can be cleared in a hospital environment. So next on to log roll. Unfortunately, because the way we're doing things at the moment, we can't formally go through a log roll, but we can talk about what the most important things are. So in terms of moving a patient in a log roll position, you have to have at least 4 team members to move the patient. You may well need a 5th team member to manage the airway if they're intubated, and that cannot be the same person that is holding the head. So often in an intensive care setting, it actually takes 5 people, with 1 person for the airway and 4 to manage. The person at the top that is holding the head is in charge of the team, okay? And they are holding the head in exactly the same way as we saw in the earlier picture, and so 2 hands either side, leaving a gap for the patient's ears so that they can hear you if they are awake. You have 3 other members, and the most important thing is that you have 3 hands on top and 3 hands underneath. You would usually have them, your team members, in height order, so the tallest person will be on the shoulders, followed by the middle, and the smallest person at the end. You can either have hands side by side or crossed over, so that these 2 team members cross over. Both are correct. Different people will teach you different things. Both methods correct, as long as you have 3 hands that are moving the torso and then 3 hands underneath moving the legs in alignment. And this is the way that you should log roll all patients if you're just doing a tilt to adjust them, or if you are log rolling for changing sheets or any other reason for a log roll. They should always be managed in this way. Okay, moving on to spinal cord injury. So spinal cord injury is damage to the spinal cord itself. It can either be temporary or it can be permanent, change in function of the nerves in the spinal cord. The nerves that come out of the spine all correspond with a particular area. So as you come down the spine, the nerves that come out supply a different region of the body as we come down. So this is when we examine patients and we can work out what the level of the spinal injury is based on their examination finding, because we know which nerves supply which area. Also, within the spinal cord itself, different areas of the spinal cord will supply different areas. So these front bits of the spinal cord that sit at the front of the ventral side of it do fine touch and proprioception. Things at the back do pain, and various other bits do your motor. So this is where we get some people with a disproportionate motor to sensory problems, is because if they've had an impact on their spinal cord from the front or from the back, it can change the way that we see things. So Asia scale, this is the way we document what spinal cord injuries we have. So a complete spinal cord injury, which means somebody has an injury from whatever level, but there is no working nerves from below that level, is called complete. If we've got somebody that has some motor loss but sensory is still intact from that level, it's incomplete. And then we go down for various groups until we have normal at the bottom. And I'll show you now how we document this with this kind of complicated looking form, but it's actually much easier than it looks. So this is the standard Asia chart that everybody uses around the world. It's standardized for everybody. And this is how we document what are we doing functionally. So at each area we can document sensation for each area. It tells you which area of the body correlates to which, and motor functions. And this way we can correlate how people are doing over time. So when they're admitting versus maybe a week or 2 weeks up to their rehab, you can see how they're going and progressing. So what kind of injuries have we got? So complete cord injury, which is our Asia A, is a complete loss from below the area of your spinal cord injury. So it's either tetraplegia or paraplegia, depending whether it's a neck or a thorax pathology. And then you get incomplete cord syndrome. So as we were saying, that you can get syndromes that are related to exactly which area the spinal cord is affected. So of these syndromes, by far the most common one we see is central cord syndrome. So this happens usually if somebody has already some degenerative disease, has a hyperflexion injury that squashes the cord, and it disproportionately damages the inside of the cord to the outside. So you see a very unusual pattern of very weak arms compared to legs, and it generally gets better. So it typically happens with older patients with hyperextension. You can have an anterior cord syndrome where just the front of the cord is affected, and then you get this kind of motor pain injury, but other areas of the cord are intact. Or you can get what we call as a Brown-Séquard syndrome, where half the cord is affected. So this is really unusual, and it's usually if somebody's been stabbed in the back and cut half their cord off, and so you get one side has a pain and temperature loss and the other side is a motor. We don't need to go into details, although it's just being aware that different areas of the cord have different functions, really. Also, if you've got damage to the cord at the bottom, you've got damage to the conus or the cauda equina, you get different functionality from different areas, and your Asia chart will help guide you exactly where your lesion is. The spinal cord also provides nervous function to all our autonomic nervous system. So if you have a damage to the spinal cord at various levels, then it can affect not just our power and sensation, but also all our organs. So it can affect the way our lungs work, the way our heart beats, the way our skin can regulate our body temperature, how we regulate our bladder and our gut. So this is where we see autonomic nervous problems with spinal cord injury patients because we can't regulate these factors as well. So diagnostics. By far, the most common thing we'll do is a trauma CT, where you do a head whole body scan. X-rays don't really have a role in the trauma setting unless it's an isolated bony injury, say in a lumbar spine, but the vast majority of things we'll do is trauma CT. The MRI, it assesses the ligaments, it assesses the muscles, and it also looks at the spinal cord and nerves. Another really important thing is if you find a single fracture, so if somebody's come in and they've just had a head and C-spine CT and you found the problem on one, you must image the rest of the body because you get a lot of missed fractures. Management. So, airway, so obviously standard management, A, C, B, C. So airway is C-spine control. If you've got a high cervical problem, then that usually affects the breathing as well, so you often end up intubated. Even in slightly lower cervical problems, they often end up having problems with their breathing as well because it affects the phrenic nerve. Breathing, obviously you're going to monitor SATs, tidal volumes, effort pattern. If there is any problems in breathing, it's really important that you escalate that up to whoever you need to go to and say, actually there's a problem here, because it may be that they need intubation. If they're beginning to work, that problem is likely to get worse, so it might be they need early intubation. Circulation, this is a really important thing in spinal injuries. You can get neurogenic shock, so any injuries above the level of T6 can affect the heart, and so you can get hypertension and bradycardia. They can look warm and dry, but because they're unable to regulate their temperature, it can often get quite cold because you're unable, because that means your sweating is affected and your ability to get goose pimples. Fluid resuscitation, so with neurogenic shock you tend to get lots of vasodilation, which is why you look warm and dry, but that means your body fluid tends to sit in the capillaries, so you have a lower circulating volume, so you normally need to give them quite a lot of fluids. And it can often mean that you can't see other sources of bleeding because it may be masked by the neurogenic shock, so you have to have low suspicion for other internal bleeding. You may need supplements of vasopressors. Disability. So if you've got somebody with a spinal injury, quite often they come in with a head injury as well, so you need to assess their GCS and the pupils. Assess them for spinal shock. Have they got flaccid paralysis, loss of autonomic function, as we've just been going through, and identify the level of injury, usually using your ASIA chart. Management. So moving on to management. Most of these patients will go into urinary retention or a flaccid bladder. Both of them need a catheter early on, because if they can't roll or manage themselves in that way, it very, very quickly run into pressure problems and skin necrosis if they are left wet. So it's really important to get an early catheter. You can also monitor their fluids in and out. And pain, if somebody has a head injury as well, often they can't vocalise pain, so it's really important to consider pain and explain anything that you're doing, because if you roll a patient with spinal injury, it's likely to be painful, so really important to make sure you give painkillers on board as much as possible. Communication. This can be something that's missed. If you've got something with a very high level injury, it may be very difficult for them to communicate, especially if they might be intubated for breathing reasons or anything else, or have a tracheostomy. It's really important to use different methods, whatever methods, and liaise with your speech and occupational therapy about how you can manage communication in these patients. So we're going to move a bit on to secondary prevention. So really important in the acute setting for immobilisation. So they normally go straight onto a spinal bed. The reason is if you've got an unstable fracture, if you've got them on a floppy bed or normal foam mattress, that fracture might be able to move. So unless told otherwise, with spinal injuries managed on a spinal bed, they usually, until they've been cleared in some way, will be on flat rest, either with or without collars and blocks, depending if they're intubated or not. And it's really important, this is something that's quite often missed in ITU, is not to tilt the bed unless it's been cleared with a surgical team. So often when we say flat bed rest, and then we'll go into intensive care and the bed is flat but tilted, why isn't that good? It may be because if they've had a leak of fluid from around the spine, you specifically need them on flat bed in order for that fluid to settle down. The cerebrospinal fluid goes from the brain all the way down the spine, so if you have an injury to your cerebrospinal fluid pathway lower down, if you tilt that patient up, the fluid from the brain is going to tank out the bottom and go out that hole at the bottom. So that's why it's really important to have it as a flat bed rest, not tilt. And also it's quite important for core perfusion, so you have a better core perfusion if they're lying flat rather than tilted. There's always going to be a balance with chest management, so if there's doubt, just speak to the surgical team and they will say whether the bed can be tilted or not. So, a bit more about specific management of fractures. There are three ways we can manage these fractures. Conservative, with an orthosis, or surgical. Depending on the level of the fracture, the anatomical structure of the fracture, and whether the ligaments and the muscles are involved will depend on which one of these two. So conservative management means analgesia and mobilise. It means that usually the fracture has been deemed to be stable and they don't need any other management for that fracture. You can use an orthosis. So we've gone through collars, which is the usual management of certain types of cervical fractures, and then we use other orthoses. So this one at the top here is what we call a TLSO brace. So that is used for thoracic and lumbar fractures. This one is a CTLSO, so it's the same as this, but with this chin extension. So we use this for people that have got multiple spinal fractures or fractures that bridge somewhere between the cervical and the thoracic region, and this one doesn't quite go high enough. And then we've got the more invasives as we come down here, which is called the halo brace, which is actually pinned into the head and then onto a jacket. And this is used for patients which have usually got cervical or upper thoracic fractures that are unstable, but we don't think they need surgery. So somewhere in between the two. Then the next things that we have on are even anterior surgery or posterior surgery, so surgery from the front of the body or the back of the body, and this can, or a combination of the two, which can either be single or stage procedures. Right, so moving on to kind of secondary prevention further down the line, so prevention complications following this. So respiratory ones are really important, and this is where we go into the importance of early clearance of the spine. So often if you've got somebody that does have fractures, we need a plan with those. As long as we know where we are going, it's really important that you don't have somebody unnecessarily immobilised, because you get complications of immobility. So if a person can be early cleared and early mobilised and those fractures looked at and deemed stable, that's really important. And don't feel worried about having to phone up the spinal team. It's really important for the patient to be able to get that done. Keeping an eye on respiratory complications, so the complications of immobility, atelectasis, pneumonias and PEs. Respiratory problems, if you've got a spinal cord injury, it can affect the phrenic nerve, intercostal, so they can't actually breathe in a deep breath in, increase work and alter the ability to monitor your rate and pattern of breathing. French complications, looking at the cardiovascular syndrome. So neurogenic shock, we've kind of gone through a lot of that. Use of IV fluids and vasopressors, they do tend to run a bradycardia. And it's important not to be worried about that. As long as they're asymptomatic about it, you don't need to do anything. Because they can't vasoconstrict their capillaries, often when you go to sit them up, the blood pressure drops. So it's quite important to really slowly sit them up when you're doing work with them, and often tilt table use and things like that can help. And temperature regulation. So they can't sweat, they can't shiver, so it's very, very difficult to adjust the body temperature. So they often get cold really quickly. So keep your patient warm, blankets and bear huggers if needed. Gastro, so prevention complicated gastro. So a lot of these, because again of the autonomic function of the nervous system, you get very slow gastric emptying with these problems, and they're unable to then defecate as well. So you can get ileus, gastric ulcers, and it's really important then to start an NG tube to decompress the stomach if we run into that. Monitor the bowel. Early feeding is really important. Often if they've not got an NG and you're worried about other fractures, people are reluctant to put an NG in, but it's probably one of the most important things for rehabilitation is that they get early feeding so they don't lose muscle. Bowel routines, every hospital will have a standard bowel protocol, and they usually will be a combination of suppositories, a laxative, plus or minus manual defecation as well, but it's usually a mix of suppositories daily that will manage that. Urinary. So again, spinal cord injury affects the bladder. You either get an areflexive bladder, which means the bladder is just a floppy sac and urine can leak out, or you get detrusor sphincter dyssynergy. So this can happen with incomplete spinal cord injuries. It's sometimes missed. It's where you've got a normally functioning bladder, but the nerve supply to the sphincter, so the sphincter won't open when the bladder goes to try and void, and so you get very, very high voiding pressures, and it's quite painful. So both of these need either a catheter or pharmacological methods to help. So monitor for UTIs. If they've got a catheter in situ, then if it can come out at an early possible period, then that's also important. VTE. So obviously the highest risk is in the first 2-3 months post-injury, and prevention is really important. There's some discussion how long you'll use VTE prophylaxis for. It tends to be if patients in hospital, they will be on some kind of Clexane. So we usually use TED, a combination of TEDs and Flotrons. We'll usually use Clexane once daily, or in large patients sometimes twice dailies. And if they can't have an anticoagulation for some reason, can consider for a vena cava filter. So monitor for early signs of VTE, and early mobilisation and hydration is really useful. D-dimers are probably not particularly helpful in this group of patients because they've got so many other causes of inflammation and injury. Those will be raised anyway, so usually would go straight for a duplex scan if you're trying to investigate for VTE. Skin. A really, really important area. So we've touched on it with nutrition and preventing wet skin with catheters, but frequent turning, documentation of those turnings is really important. Proper fitting braces so you don't get pressure sores under the chin and on areas where braces fit. Appropriate mats and mattresses. And if you do get a pressure sore, early intervention with a tissue viability specialist. Sometimes you'll need surgery for this if you get a deep pressure sore, and obviously it can cause delays in their rehabilitation. Musculoskeletal. So you can get spasticity and contractions. Often these aren't always preventable, but if you can keep a really good physio program, you can often keep mobility to prevent spasticity, and that can really help, especially when you're beginning to work on patients' core stability and transfers. If we've managed in that acute time to avoid that, then it really helps with their rehabilitation. If they do start getting contractions, you can speak to the rehab team, and sometimes antispasmodics and Botox, along with a combination of splinting, can really help. So just coming on to the last bits, how do we contact the spine team at NBT? So in the acute patient, we use refer patient. So you just go on to www.referpatient.org, put in Southmead, put in neurosurgery. Spine will come to the neurosurgical portal. So if you've got any questions, just come put the referral in, and that is manned 24/7. So you'll always get a response on that. If you need to contact the Spinal Injuries Unit, again, it's an online portal, so if you just Google National Spinal Cord Injury Database, it will take you to this site. Anyone can have access to it. You don't have to have previously done referrals, so you can do a new referral on that. So if you want to contact the Spinal Injuries Unit, this is the way to do it. And in this trust, if you've got any questions about spinal injuries or spinal cord patients and just want to ask a consult, like maybe about a brace or about a plan of patient, these are probably the people to contact. So on the neurosurgery side, we've got Laura, Anita and Bernice. They always carry their bleep 1153. And on the ortho side, we've got Marie and Jess, and they're always happy to be bleeped. So take home messages. Early management plans for spinal fractures is really important so that we can get people mobilised as quickly as possible. Prevention of complications is really important, and if in doubt, just ask us and we're more than happy to be asked about anything. Thank you.